Self-care and critical reflection are integral to maintaining one's well-being and ensuring a patient-centered approach to practice. We've invited 3 RAAM clinicians to speak about their own experiences with self-care and how they maintain critical reflection in their clinical practice.
So, as we go through this work, I think there's a lot of struggles just on the sort of the personal and emotional side of being a practitioner and working with this client population. Would you be able to perhaps reflect on maybe your less successful cases, and what are the things that you learned from these situations and that you now apply in your practice? You're getting right in
I don't know less successful. I would call it maybe ongoing and trying to sort out. Maybe that's a different. So I was talking earlier about this sort of outreach piece, right, and making these outreach efforts to connect with people, and how far do we go with it in terms of not being able to connect, or I've done work in mental health where the outreach can go on for a long time because we know that it takes a long time and it maybe takes quite some time to make that connection, right? This is a little different because I'm working in the context of a RAAM, so I'm sort of looking at what are the parameters around that? When we sort of say, okay, let's leave, that's for now, that person will contact us or we'll try again, so sort of walking away from those efforts. And as we're new, we're sort of getting to that point where we might have sort of a group of people kind of floating around out there that we're still trying to make contact, or maybe they reach out occasionally. And I guess, we're just working on keep always, of course, the doors open. But how much time do we continue to put into that is like where we're kind of going. And as we get busier, that might be answered for us as well. But I think, so capacity will probably answer some of those questions for us. So I think that's kind of where we're at. But and I think just to our earlier point about keeping people safe and trying to build in as much safety as we can around people that are using a lot of opiates and maybe not ready to try the replacement therapy, but ensuring, maybe they still are using and on Suboxone, and how do we create as much safety as possible in safety planning. So I think those are the things that come to mind. So wouldn't necessarily say least successful, but ongoing issues around support and connection. So.
Yeah, I guess I could talk about one case where we tried all that.
Yeah, it is. The follow-up.
And it still didn't work.
Yeah.
And this is a particular case where someone who, the larger issue is mental health. And psychosis that's not being acknowledged or treated. And so, I guess I really wish I could have convinced or got that patient on board for some antipsychotic therapy. But I had an ongoing relationship, even prior to RAAM in my other clinic with this patient for years, who would come and go, but then would just become violent, broke windows. And that's kind of where, I have to draw the line. And especially because that patient wasn't engaging in the therapy that was recommended by many psychiatrists and myself. And so, I wish I could have got that person on board, and I don't know how that person's doing now, but when it gets to a point where they're refusing the treatment that they need, probably due to a lack of insight, not quite where you were going to form them and force them into hospital, which I considered. So it's challenging because you do have to draw the line and set limitations. I'm not a psychiatrist, I did reach out to psychiatrist colleagues for some suggestions. This patient was involved with some outreach workers who insisted that I was the only physician that patient would, agree to see. But then at some point I said, well, I can't see that person anymore. The person's not following through with my treatment recommendations, is coming in and trying to dictate to me what I'm going to prescribe. I got to a point where I wasn't feeling safe. And so I think when you get to that point, you try your best, and you have to say no sometimes. And I hope that he finds his way, and maybe he'll probably end up hospitalized, and maybe on some proper medications. And my kind of thought on that case is, if he's taking the medications that are recommended and he's settled, then I'll take him back. But up until that point, I'm not willing to see him too volatile, too much risk to myself and to the staff. And so, there will be people that you do have to set boundaries with, and to understand that maybe sometimes that's better for the patient as well.
I think sometimes telling yourself that you need to set boundaries is also very difficult as well. Even if a client like yours, is sort of giving you all of the reasons why it would probably be very prudent to set those boundaries, but I still think practitioners find that very difficult, as you said before. But
I think that one way to get over that too, and it's harder with the people who are more severe mental health, is that I really am a proponent of the patient taking some self-responsibility. I mean, a lot of these people have challenges, but some accountability for their own behavior and their own treatment plan is really important to me. That's how I practice, is that I think all our team members are working hard to help you get better. I expect them to work a little bit as well. And if time and time again, they're not engaging, or they're not really moving forward, sometimes, kind of like what you said, you kind of step back. I mean, if there's no safety issue, stepping back is the way to do that, and to because you can get exhausted. You're putting all this effort in, you're trying so hard, the whole team, and the patient's kind of just floating and not really doing much. And then so at some point you got to say, we're trying way harder than this person's trying. Maybe we need to take another just harm reduction approach and just keep the door open for when they're ready to really engage. And so that's how I kind of make myself feel a bit better about maybe some of the ones that aren't going so well. And so sometimes you do have to, and that's kind of what you had said, you can't throw everything into every patient all the time, and you have to be selective.
And just to add on that, and to kind of adding on to Irene's point about if I know a person has connection with like a drop-in or a shelter or a particular place, like and they've said, yeah, it's fine for you to talk to the staff. I'll call the staff there and say, listen, we did several attempts, or but the door's open. Like, let the person know if there's any change, like just give us a call, or we'll come out again. So kind of building that into with the supports that I know that where the person might actually be continuing to use, right? And here in Toronto, drop-ins is one of the big ones, right, where people will go for sort of basic needs and practical supports, even if they're not engaging with other particular services.
Okay. I think our approach is very similar to Sam. I often tell outreach workers that it's important that you're not working harder than the patient, and so our work is really, number one is safety, right? Once we can try and make sure that we mitigate the risk for the patient. And all of us work with an openness that we are here to meet the patient where they are at. And so some of them are ready to make some changes. Some of them are not ready to make some changes. I don't think that it's at a loss that they have come. Maybe their priority is not to make any changes at all with their substance. But I also have my personal understanding that no single person is all bad. That if we give people enough time, they will eventually show us some sign or some good in them. And so I like to communicate that with the patients too, that, we've tried to put a system, you have helped us to put a system for you that we thought, or you actually told us would help you and would work. You're still not able to maintain that, and that could be for various reasons that I or my team don't understand. At this point, however, we have kind of limitations to what we can do, and we are bound to some regulations. So our door is open. Should you feel that this is a service that you can benefit from, we're here. Should you feel that there's something we can support you out there, that you don't need to come here, but maybe we can be able to send a letter or for somebody, this is our number, you can reach us. So I leave it open, but I also feel strongly that it is not going to be worthwhile to be working harder than the patient is willing to participate and to give in.
That's a really good segue into my next question, is because this work can get to the point where you do feel like you are doing so much more, and perhaps you're not seeing, you know, in terms of the benefits of your work. And so in this case, you know, self-care is really, really important. What are some things that you do in order to maintain your self-care, to rejuvenate you, to keep you energized and motivated about this work? The good coping. The good coping.
I mean, for me, the big part is for me to set boundaries. I'm available from here to here. I'm not going to be available for this time, and so that's step one. Because if you're constantly available, that's not going to be good for yourself. And then you know, I mean, I think everyone has their own self-care approaches. So as long as you're doing something that's not work-related, whatever that is, and it's healthy, then I think that's key. But as you know, for me, it's boundary setting, right? And being available to your team, but you don't have to be available 24/7, especially if you have a team, and to make sure that you're reinforcing that to your patients and to your team. Because your patients need to understand that you're not there 24/7 as well. And again, that gets into the patient accountability aspect. So, missed your appointment, you didn't call, you don't have your dose. Like, that's not on me. So I don't know. I mean, for me, I've been able to do that. I could see it is challenging for some people, but I really cope with that aspect of things by bringing it back to patient accountability. There's only so much I can do for that patient as a physician, and so again, that's the boundary I have personally, that I expect the patients to be, making some of their commitments to their care, and when they don't do that with a good reason, then I feel a little more comfortable not stressing about it, because it's a partnership. This treatment plan, there's two people involved. It's not all me, and I'm not going to, by any means, be the only person that's going to make them better. So if you go in thinking that you, as a single prescriber or social worker or counselor, you're going to be the only person that's going to fix all their issues, it's not a good way to approach it, because then you're taking on way too much yourself. So.
Yeah, I agree. I think a team approach is really a good way to work, right? And I think we've all touched on that, and I think that's so helpful. That it's not just one of us that's going to resolve or solve all of the issues, and there's only so much any of us can really do at the end of the day. We'll do the best we can, and to Irene's point, sometimes people aren't there. They may still be thinking about a change, but it's not their priority maybe right now. And understanding and respecting that is also, part of like looking up for ourselves too, right? It's like, I have respect, that's where you're at, I get it, and being able to be okay with that and where people are at. And I think for me, the organization is very supportive of people's care. You can access traditional elements of the organization, like staff are encouraged to go to the sweat lodge each week. There's Thursdays that people can go after work and to access the healers if they want to, if that's something that's important to them. So there's sort of some built-in self-care in that respect of accessing some of the resources, which I think is great. I think just knowing that we all have our limitations, and you have to kind of respect that in yourself and others, and that's how you kind of stay going. You don't burn out. I think, right, is that because the work can be overwhelming, and you have to keep your perspective, I think, and bring that to it. Yeah.
I agree, especially with boundaries. I'm firm on them, and I say sometimes when you say I set boundaries, or even when you're setting them, it can appear you're too tough. But I personally, I think it's in my character that I like to be very honest. Even on very unpleasant situations, I don't have a problem doing that. And from the get-go, I employ the same principle with the patients. I tell them that I have limitations. First of all, I cannot prescribe any medication to you. I may care so much about your recovery and all of that, but if you do not meet the expectations with the physician, I can't help you. So you have to help me to help you. So that is really communicating what my limitations, what my capacity is. And number two, I like to bring in the team support and what exists within the team, right to the point where the patient understands that we all work together, we are one unit. So the fact that Greg, as your physician, does not, agree with these things that you want, maybe a medication increase or changes the dose, and you're seeing me for supportive counseling, we are on board, we are the same team, we communicate, we are all working towards the progress and good outcomes for the patient. Because sometimes even as a team, if that is not reinforced, sometimes, we work with a population that may tend to, split those kind of roles, differences. And so I make it very straight that we work as a team here, and we look out for each other, and most importantly, that is to help our patients. The other thing that helps me too is kind of the same trauma-informed approach that I employ for the patients. I also employ that for the people that I work with, that there is no us versus them with patients, that the same experiences that they may have come with, us as a team members, we may have those experiences, and sometimes one person is going to have a bad day, sometimes the other person is going to have a good day. And so I like to be very open in saying, having that openness with my team, that I am able to say, no, I cannot see your patient today, Greg. And I have the advantage and the privilege that I think my team knows the way I work and the kind of person, and so I am able to get that support, because it's very important for self-care. And that if my mind is not there to do that, that people appreciate and respect that. And I can pick out also from another team member that this is not like the case that I gave previously with one of our physicians really feeling the frustration of the patient. So because we have those open conversations, then you understand how people are feeling. And then you step in where you can, and you allow people to know that it's okay to do that. And we don't have this role kind of barriers that, you are a physician, you are a nurse, stay to your lane kind of thing. Is we are working together and we are looking out for each other. So that is my approach for self-care. And obviously, the smiles go a long way, even with patients. I am the kind of person, if you saw something funny, I want to hear it. I want us to laugh together. That really is very therapeutic for me. Yeah.
So I think that's very, very important, the importance of supporting each other as a team. And also, the risk of even just vicarious trauma, right, among your team, because you are dealing with sometimes some very, very serious situations that come with a lot of risk, and for both the client and yourselves. And so it's really important to support each other as best as you can, as well as maintaining, your health and your well-being. So thank you so much for coming and talking to me today. I really appreciate it.